Hello, everyone. Welcome. Welcome to the Erythromelalgia Association's webinar. My name is Beth Coimbra. I'm the president of the Erythromelalgia Association. It is my pleasure to be able to introduce our presenter today. Her name is Kathleen Orrico. Has been a pharmacist for over 40 years, which she has said to me this morning that she just can't believe that that it's been 40 years that she's been at this. And she is also currently a professor at the University of California, San Francisco, in the College of Clinical Pharmacology. And she has put together a comprehensive presentation for us today entitled Drugs and Your Genes. And I thank you all for joining us and your interest. And I will now turn it over to Kathy.
Thank you, Beth. Hello, everyone. It's very nice to be with you today. And I'm going to thank you in advance for everything I'm going to learn from you about your experiences with drug therapy. So today we'll talk about drugs and genes, and we call this now pharmacogenomics. It's a somewhat new discipline in pharmacy practice. And it allows us to personalize or better fit drug therapy to your individual body. Uh-oh. Why isn't this advancing? Oh, there we go. All right. So hopefully, especially at the end of the talk today, we'll be able to have a more of a conversation and a back and forth. And what we're going to discuss is how your genes can influence how your body metabolizes a drug. And we'll talk about what we mean by that. We're going to discuss how your genes can influence whether a drug works for you or not. And sometimes how genes can predict your likelihood of experiencing a side effect. We're also going to talk a little bit about how genes are related to the cause of erythromelalgia. As you probably all well know, it's not in everybody, but in a good proportion of people. And then we'll just talk very briefly at the end about the new non-opioid pain treatment, suzetrigine, and why it may, underline may, be well suited to treat EM pain. But before we do any of that, we're going to go through some very basic genetic concepts, and I do mean basic. Realize that this is an ever-evolving science. It's a recent science because we've only been able in the last about 10, 15 years to really get into a gene and type it and see what that gene is made of, and then to be able to bring that into the clinic. That's a recent development. So we're going to talk about DNA, which makes up your genes, and how that relates to proteins that function in your body. Okay. So variations in genes we call genetic variation. So your genes are made up of DNA, and DNA is packaged and stuffed into almost every cell of your body in the nucleus. And it's divided up, if you will, into chromosomes. And on those chromosomes are areas of DNA that are your genes. There's about 20,000 protein coding genes in the human genome. So when you hear the term genome, it applies to your entire set of DNA. So what does a gene do? Protein coding genes, those 20,000 genes, hold the recipe or blueprint for making every protein in your body. If you change the DNA pattern and change the gene, you may change this protein. Sometimes it's of no consequence at all. Other times it can be disease causing. Other times it can affect how we process a drug or whether a drug works for us or not. Also, you'll see different names for the same thing. So you probably know this as I have a mutation in my gene. All that means is a difference. So you'll also see the term gene variant or gene allele. It all means the same thing. It just means that a gene is a little bit different from the gene that most people have. And that can be most people in the world or most people in a given population. So tuck that away. Genes hold the blueprint for proteins. Well, are proteins that important? Yes, they are. Proteins do almost every cellular function in your body needs a protein of some sort. And proteins are molecules, and they're very dependent. Their activity can be very dependent on their shape. That shape, in turn, is determined by that blueprint in a lot of cases. So enzymes are very important to drug therapy. You have a whole set of enzymes in your liver that metabolize or chop up drugs and any other foreign substance you might take into your body. For erythromelalgia, for some people, maybe for all people, maybe they'll find that out, that cell surface components or structures that live on the surface of nerve cells, in particular the voltage-gated ion channels, their function, their structure is dictated by a gene. You also have proteins in your immune system, the HLA-B and HLA-A proteins that live on immune cells. And they can determine whether you have a reaction or a hypersensitivity reaction to a drug or other things. The receptors that many drugs plug into often have a protein component. Peptide means protein, and a lot of your hormones have a protein component. Drug transporters. So it's really hard to get drugs in and out of different places in the body. And there are molecules that lift drugs in and out of cells or between different membranes, and those are transporters. Cytokines are proteins, and that's just another signaling chemical in your immune system that takes part in inflammation and other processes. So that's just to give you an overview that proteins are important for many, many functions in the body. So first, we'll talk about drug metabolism. Much of the application of pharmacogenomics, at least at this point in time, involves predicting somebody's ability to chop up a drug, get rid of it. If you aren't good at getting rid of a drug or metabolizing that drug, it can back up in your system, if you will, or it can increase its level in the bloodstream. And that can either be of no consequence or it can cause toxicity. So we'll talk about this super family of enzymes, the cytochrome P450 enzyme system that live in your liver cells. So as I said, it's a family of enzymes. And for most drugs, the metabolism is well worked out, and certainly a new drug that comes to market that I'm sure the FDA and other regulatory bodies require that those studies be done and that information is known. So we know a lot about these enzymes. Realize there's other processes that can go on with the molecule as well, and different pathways for metabolism. Goal is mainly, for the most part, to make things more water soluble. So you excrete it in your urine, but you can excrete drugs in many different ways. So the CYP3A4 enzyme metabolizes most drugs, but it doesn't vary much from person to person. So we say that that is not polymorphic, that it tends to be the same in most people, at least what we know now. But it's very much involved with drug interactions. Some of the really big drug interactions occur because you have multiple drugs trying to use this enzyme. But for our purposes, it's not one of the big players. The big players are CYP2D6, CYP2C19, and CYP2C9. And those enzymes vary between people, they're polymorphic. So that's the basis for a lot of what we do with pharmacogenomics at this point in time. We want to know your individual ability, your individual enzyme function, just to predict how well you will process a drug. So to make this into a form or define it in a way that it can be used clinically, we have expert groups that read the literature and pull all the information and put their collected wisdom together and give us recommendations. So one group, the Clinical Pharmacogenomic Implementation Consortium, CPIC, writes really good clinical guidelines for us to use in the field. You know, it would be a rare doctor or pharmacist that could do that for themselves. So we depend on these expert groups to collate that information and give it to us in a form that's workable in the clinic. And we're very grateful to these groups. PharmGKB, the pharmacogenomic knowledge base, lives out of Stanford. They also gather information from international boards, from CPIC, and they put this up so that the providers and the public can use this information to dose drugs for the most part. So they've created metabolizer or metabolic categories based on somebody's genetic profile. So we have people that don't metabolize a drug well, the poor metabolizers, intermediate metabolizers, normal metabolizers, rapid and ultra rapid metabolizers, for each of these genes of interest where there's good evidence. All right, so what does that really mean? First, let's talk about what is a genotype. So a genotype identifies the two gene variants that you inherit. So for every gene, you have two copies, one from mom and one from dad. Little side note, sometimes you will have multiple copies of a gene and make a lot of a protein, or sometimes you'll have a deletion and the gene is missing. But that said, for the most part, for every protein coding gene, you have two. Now, what if those differ in function? You could have two normal ones and you would just process a drug as we would think you would. Or you could have one enzyme that's produced that doesn't function well and one normal one. Or you could have two duds or missing. So CPIC puts that all together for us, and we can look at somebody's genotype, and this is what you would get if you did genetic testing. So in this case, this is for the cytochrome P450 enzyme 2D6. This is the gene, CYP2D6. That's the symbol for the gene. And this individual has a star 3 allele or variant and a star 4 allele or variant. We would look this up on charts and see that this person is a slow or poor metabolizer of drugs that use the CYP2D6 enzymes. So that's how the testing translates to a metabolizer category. And then we look at CPIC guidelines and dose you. All right, so let's use an example with venlafaxine, Effexor. This drug uses CYP2D6 in its metabolism. This is an antidepressant. It's been well tested to treat pain and especially neuropathic pain. It increases serotonin and norepinephrine at the nerve juncture, and it also affects dopamine. It's metabolized by the CYP2D6 enzymes. So if you're a poor metabolizer, you can accumulate this drug and you have a hard time getting rid of it because you don't have enough active enzyme. In this case, doesn't cause dire toxicity, but it can make people really uncomfortable and can experience more drug side effects such as anxiety, agitation, confusion, uh, heart rate increases, and the like. So, since this is very well proven, if you will, in the literature, CPIC issues a dosing recommendation based on that metabolizer category. CPIC is very conservative. They will only issue guidelines if there is an action we can take in the clinic. If they may know that there's a strong relationship between a drug type and a gene, but if it's of no clinical consequence, they don't issue a guideline. So if I'm a poor metabolizer of venlafaxine because my CYP2D6 enzymes aren't up to speed, CPIC recommends that this drug be avoided if it's possible. Other strategies, other recommendations say that you can start at a reduced dose. So let's look at amitriptyline. A lot of you have probably tried this. It's a great adjunct med for pain. It started out as a very good tricyclic antidepressant, a very old drug. I think it goes all the way back to the 50s. But it also works very well to treat neuropathic pain. It helps modulate 5 neurotransmitter pathways and reduces that pain impulse. Unfortunately, this class of drugs can cause real toxicity, but it does that at very high levels that are typical of overdose situations or when we're using very high doses to treat depression. This is why amitriptyline is rarely used for depression anymore, but it has a nice use for pain. And realize that the recommendations for using it for pain, we dose very low. So I don't want to scare people about this drug. Nonetheless, it has a narrow therapeutic window. And what we mean by that is if you don't give enough of the drug, it might be ineffective. But if you give too much and have high blood levels or tissue levels, it may lead to toxicity. The worst toxicity is heart arrhythmias. We call it QT prolongation, and these can be very severe and they can be deadly. Once again, this happens in overdose situations. Interestingly, this drug uses CYP enzyme systems for its metabolism, CYP2D6 and CYP2C19. So you've got to really consider someone's ability to use both these enzymes to ultimately metabolize the drug. So amitriptyline is what we call a parent drug and needs to be converted to its more active metabolite to really be effective. So the conversion from amitriptyline to nortriptyline uses the CYP2C19 enzyme system. So if you don't have good functioning CYP2C19 activity, you may just get more parent drug, which is a little bit effective, but not as effective as nortriptyline. And you might not get a lot of effect from this. To get rid of the drug or excrete it from the body, you use the CYP2D6 enzyme system. So you can see how complex this can get. But we have strategies for dosing people knowing both these. But I just wanted to show this to you that sometimes there's more than one gene involved in the metabolism of a drug. So the standard dosing for neuropathic pain, as I say, is really low, 10 to 25 milligrams once daily at bedtime. You can increase that dose at weekly intervals. to 150 milligrams per day, and we would divide that dose. So here are CPIC safe use recommendations. If you aren't, and I'm just doing the the 2D6 side of things. If you're a poor metabolizer, we can still use the drug, but let's start really low. Let's use that 10 milligram dose. Or if someone has a lot, let's say you had a patient that has already has heart issues, you may want to avoid it. People that are a little bit compromised in their metabolism, the intermediate metabolizers, we would also use a reduced dose. Maybe we'd start at half of a 25. For people that have great CYP2D6 activity and chop up drug really quickly, we worry there that they'll be subtherapeutic, that the drug won't work. So we might start at a higher level. Let's start at the 25 and go from there. So that's just to give you an example how practitioners think about this information and select a safe dose for you. This is an example of a pharmacogenomic testing report. One is out of the Mayo Clinic. It is it's a private business, but they do pharmacogenomic testing. And this is an example of what a report you may receive or your physician may receive. So you'll see the gene listed and then the genotype. Okay, which two genes does an individual have? And then they do interpretation for you, and they'll give you that metabolizer category. The CPIC, PharmD, they're trying to get us all on the same page. They're trying to get us all to use the same language and the same testing and the like, so that this information can be easily translated into practice. So I just wanted to show this to you so you get an idea what the results might look like. So can pharmacogenetic testing really help you pick out the best treatments for EM? And by that, I mean safe and effective. Yes, to some degree. So we've talked about for specific drugs and specific genes, it does help us predict someone's ability to metabolize a drug. It's not every drug. Now, it may be in the future as more and more studies work out, it might be that we know a lot more about every drug and its relationship to your gene profile. But for right now, it's kind of spotty, and we'll look at some of that. My favorite part is that we can avoid some of the serious side effects with pharmacogenomic testing. Once again, that's for just a few drugs that we can do that for. And it does allow us, if we know the information, to dose drugs appropriately. So I just pulled a few drugs that are used for EM treatment, and that's treatment mainly of pain. To give you an idea, so we talked about amitriptyline and the two genes that tell us how, give us information about properly dosing it. We'll talk about carbamazepine, the old Tegretol, and how HLA-A and HLA-B testing can help us predict side effects. Codeine, which needs to get metabolized or converted to morphine for it to work, needs active CYP2D6. If it has two active CYP2D6, all of a sudden people can get a lot of morphine in their system. So we're not going to talk about that today, but it gives you an example of how this is used. Phenytoin, the old Dilantin, it's an old seizure medicine, but still widely used and used as for adjunct in pain control. Has a couple genes that can give us information. HLA-B testing for specific variants can tell us if someone is more prone to side effects, and they're cutaneous side effects. And CYP2C9 can tell us about the metabolism of phenytoin. Then there's tramadol, and we talked about venlafaxine. And there's more, and this gets updated. Just to give you an idea that right now it's certain drugs and certain genes. So as I said, probably the best thing pharmacogenomics can do is predict risk of toxicity and side effects for certain drugs. And one of the best examples of that is carbamazepine and its buddy drug, if you will, oxcarbazepine. These drugs, once again, carbamazepine is a very old medication, maybe as old as I am. And a good anti-seizure medicine, but it also has a role in pain control. And it's been known for a long time that these drugs can cause horrible skin toxicities. And we used to say, oh, it's idiosyncratic. We can't, it just happens. And it's rare, but when it happens, it's awful. Stevens-Johnson syndrome, toxic epidermal necrolysis. In essence, it's as if you're a burn patient and the skin sloughs. And we treat this horrible complication as if someone's been burned. Well, now we can do genetic testing that at least helps us weed out, if you will, people that are more likely to experience this toxicity. And that's with HLA-B and HLA-A gene testing. So what are these? These are human leukocyte antigen genes. And what HLA is are protein molecules that sit on the surface of immune cells. And they signal the immune system that something's not right, that there's a foreign invader and come and attack it. Well, that can be triggered, if you will, by certain medications. Carbamazepine, phenytoin can sometimes do this, and a few other drugs used for HIV. So if we, and this has been related to having one or two, at the worst, copies of very specific versions of a gene. So this HLA-B 1502 allele or variant, or HLA-LA-A 3101. If you have either of those alleles, we would never expose you to this drug. This is an area, this is part of immunology, and it was somewhat well worked out before it had a pharmacogenomic application. And because of this, we know about the occurrence of these alleles in different ethnic populations. So if you're of certain Asian descents, you are more likely to have these variants and therefore more likely to be a setup for this terrible toxicity. It's still very rare. In the general population, these terrible skin reactions occur 1 to 6 times in 10,000 people. But if you're of Asian descent, that number is 1 to 6 in 1,000 people. And although that's still rare, these are deadly toxicities. So next, I'm just going to quickly go through a treatment algorithm for EM. I had to educate myself on, what are the treatments that are used. This is from a source that we use in healthcare to date. Physicians use this, pharmacists, nurses, and think of it like cliff notes or cheat sheets for diseases, treatments, all sorts of topics in medicine. They do just what the name says. They glean the literature, they pull together recommendations, and they have experts do this. Now, there's a caveat here that this is simply just one pattern of treatment. You also, in your wonderful guide that was sent to me, have treatment recommendations. So these are not really set in stone. They help a physician really know where to even begin. So a lot of this you're going to know. Aspirin They like to put people with EM on aspirin because it goes hand in hand with myeloproliferative diseases that can cause blood clots. But that's not everyone, and your physicians and your neurologists will make that call. They recommend first a trial of topical therapies. We like topical therapies in healthcare because it spares the drug from becoming systemic, or it limits the amount that you can absorb into your bloodstream, into your body, and we hope that gives you less side effects. It's not always the case. Sometimes things are absorbed through the skin very well. Nonetheless, they recommend, I'd love to talk to you about what you've used and what has worked and what has not worked. But anyways, they recommend topical amitriptyline and ketamine, midodrine, which constricts blood vessels and hopefully interrupts or keeps that inflammation and pain at bay. Lidocaine patches. We use this a lot for all kinds of pain treatment. Uh, there again, it's to spare a lot of systemic absorption. You apply it, and it's important, as any of you that use this, to know that you really do want to break daily from this. You don't want to keep it on 24/7. Um, Next, they say, so if that doesn't give you relief, you start thinking about things systemically. So gabapentin and pregabalin are interesting drugs. They have no pharmacogenomic relationship at all, at least as far as metabolism goes, because these interesting medicines undergo very little metabolism. You take it in, you excrete it, pretty much as parent drugs. So some people get great relief with this and others not so much. They have side effects of drowsiness and the like. Venlafaxine, we talked about interrupting pain signals. And we talked about that and why that works. If all that fails, then you can start using other adjunct pain meds. Amitriptyline, misoprostol is a prostaglandin, but it does play a role in mediating pain. Sertraline, now we're into our other antidepressants, and then the sodium channel blockers. So we'll talk about how that might make sense for EM because there is probably a defect in a sodium channel that helps transmit the pain signal. So mexillatine, lidocaine also can work in this regard. They inhibit this influx of sodium that helps carry the pain message or pain signal. Carbamazepine works here. And sure enough, the new drug, suzetrigine, hones in on the sodium channels. They also recommended, and I hope this is available to those of you that need it, good pain management programs. They're hard to come by. They tend to live at big university medical centers, but they're very helpful because they will use all types of lifestyle interventions, you name it, acupuncture, relaxation techniques, all that to help you cope with pain. So when would pharmacogenomic testing really be most valuable? Probably when you graduate from topical drugs and are thinking of using combinations of systemic drugs. Also, if you have a lot of other chronic diseases and you're on a lot of medications, it might make sense to have a pharmacogenetic or genomic testing profile done so that your provider can see how all these different drugs may work and interfere with each other. That's in addition to an analysis of drug interactions. Certainly, if you're ever going to take carbamazepine, I would want to be tested in this day and age. I know it's rare, but I would want to know. And then there again, when pain management progresses and you have to use lots of different combinations of medicines. But how do you get tested? Always best to partner with your physician and your team. They really know what's best for you. It's likely that if you wanted this testing, they would recommend where you get tested. Your medical center may do that testing for you. This is coming along very nicely, and more uh, physicians and medical providers are offering this to patients. If you go to a private company, they, for the most part, require a physician referral. They want your physician to be on board so that they can orchestrate your treatment. And it really does work best that way. I present to you one ohm. It's the one I'm familiar with. That doesn't mean there aren't others out there. They offer a package, the Right Med package, very much based on CPIC guidelines, very comprehensive, but it has to be ordered by a licensed healthcare provider. For EM testing, I learned it at the last time I spoke with the support group that Quest Diagnostics is the group that does SCN9A gene testing. So let's talk about that a little bit. You probably know much more about this than I do. But in some patients with erythromelalgia, primary erythromelalgia, 15% carry a gene variant of the SCN9A gene. So what this gene encodes for is the sodium voltage gated channel. So this is a channel that lives on nerve cells and in nerve plexuses or groups, or think of it like an electrical transit center that help carry the pain signal back to your brain. And that's where you perceive pain. So charged sodium ions, flux in and out of this voltage gate. And that's what directs and sends the pain impulse. Part of what they think goes awry with erythromelalgia is this sodium voltage channel is not functioning properly. And that's because the gene that encodes it has been changed, and it's making this faulty channel that's open more than it's closed, and is hyperactive and sending pain signal to your brain. And it's probably doing other things too. We know that your blood vessels are involved in this as well. So the treatments, at least at this point in time, are more directed at relieving pain, calming that system down as much as we can, and not really correcting the gene. But that may be coming in the future. So I don't know how many of you have been tested as part of your diagnosis. Um, But if you have, realize that you may have a problem with a gene or one of your sodium channels that we're not testing for. So these things are in their early stages so that they know the SCN9A variants to test for, but there may be ones that we don't know about yet. And then there's other genes that encode other sodium channels, the SCN10A, SCN11A. So realize that testing will tell you if you have one of these variants, but it certainly won't tell you about things we're not testing for. So stay tuned for this to change. The benefit is that this is a dominant gene. So if you are positive for this, you can pass it on to your offspring. I don't think that's 100%. You would have to talk to a genetic counselor on that one. But it's would be good to know that. Once again, the limits are that we might not know all the causative mutations at this point in time. We probably don't. I'm going to guess that if you want to be tested, that this would certainly be covered. Your neurologist would know how to pose that to an insurer, and it's Quest Diagnostics for the most part that does the testing. So that brings us to this brand new drug with a brand new mechanism of action, suzetrigine or Journavex, suzetrigine. So everyone's very excited because this is a non-opioid pain medication. And you can imagine that there's many, many applications for that. People that just don't want an opioid drug at all, yet are having surgery or need an analgesic. But because of its mechanism, it may be really good for pain with erythromelalgia. But we're going to discuss how we have to be very, very careful with that at this point in time. So whenever we encounter a drug with a new mechanism of action, we kind of know in healthcare that it's, unless you really need to be the one that tries it, it's good to buy yourself a little time. We never know with new drugs what's going to be the final or the long-term side effect profile. We just don't know what we don't know about something that's not been tested in the general public in millions of people. The FDA, the European bodies do a wonderful job of really trying to be so careful with clinical trials and predicting whether a drug is going to be safe for public use. Nonetheless, you never really know the whole story until it's used in millions of people. So it's not always good to be an early adopter of new medicines. That said, the way this drug stops pain is it blocks those sodium channels, the ones that are too hyperactive in erythromelalgia. Do we really know that that's going to be a wonderful treatment? We really don't know that yet. It's certainly being studied, but it kind of makes logical sense that it might be very well tailored for blocking that pain signal that's overactive from the periphery. Right now, so there again with new drugs, we like to use them in accordance with their approval, which is based on the studies that were done. So this drug was studied for moderate to severe short-term use in post-op pain. And it was tested in people that have had abdominoplasty and bunionectomy, short-term, 14 days, to relieve that pain. And what was found is the pain relief was good. It was akin to Vicodin, which contains the opioid hydrocodone with Tylenol. So my guess is that's exactly how it'll be used. Post-op, acute pain, broken bone, for someone that really has to avoid opiate use. So you load this drug. You take it 2 tabs initially on an empty stomach. That means it interferes with food. And then you take 1 tab, 50 milligrams every 12 hours. Once again, it's limited right now to 2 weeks use. So this right now, we don't, its metabolism doesn't involve any of the drugs that are highly polymorphic. So we probably wouldn't do pharmacogenomic testing to use this drug safely. But there's that CYP3A4 enzyme that that metabolizes most drugs and causes a lot of drug interactions. This is also a drug that you wouldn't take with grapefruit juice. There again, it inhibits 3A4 enzymes and can raise the level. The side effects right now, we don't really know. They seem mild, rash, itching, muscle spasms. But as I said, with new drugs, we're very vigilant. Should you be that individual that really needs to try this drug? that's okay. I'm not trying to scare you, but you want to be extra vigilant. You want to pay attention to anything that develops. And it's very helpful if a side effect is experienced that that's reported to your doctor and that you or your doctor reports that to FDA MedWatch. Um, so I'm not trying to scare you with the new drug, but we do want to exercise some caution. So there we have it. Take heart. As you can see, we're at a really great point in medicine that so many advances in genetic science and basic science are presenting new treatments for disease and new understandings of how our body works. So that's it for today. I hope I didn't go too fast, or I hope I made sense, and we can field some questions if you'd like. Let's see. Meg will help me out with this too.
Yes. Hi, we have some questions in the chat. The first is
Okay.
from Jennifer Berry, and she wants to know if the genetic testing that you're talking about is similar to Gene Insights testing, which also tells you which medications might react well or poorly, and if it's the same kind of testing.
It is. And what I've noticed for most of the genetic company reports that I've seen is they're very similar because rightfully so, they're based on those good solid CPIC guidelines. And other in Pharm GKB recommendations. So people are trying to keep it very tight, if you will, and talk the same talk, categorize things the same way, and test for the same variants. Now, there is a little bit, sometimes they'll include things where there aren't recommendations, but they base that on pretty good evidence. They aren't going to just, you know, uh, tell you things that probably don't matter. They're pretty careful, is what I'm trying to say. So yes, they're all very similar.
Do we have any other questions? If you have a question, you can just put it in the chat.
I hope that made sense. Also, if you think of something in the future, feel free to email me. Most things I have to look up, but that's okay. I learn a lot from doing that.
Well, this was really wonderful, and we're getting comments that it was great, and thank you. And
Oh,
it
thank
really
all of
was
you.
terrific. Yeah, and I think it really helps people understand sort of how their bodies metabolize medications and that there's information that can help them make better choices on what medications to try. Okay, we have another comment. It's, as a general opinion, how do you most often see people deal with EM, substance avoidance or drug management?
Oh, that I don't know. You folks are gonna have to answer that. So I would be biased and say drug management because that is what I see. So see, I learn from you folks. So I'm going to see those prescriptions and the drugs, but I'm not going to see the people that don't use those things.
Yeah, I think everybody has to talk to their own doctor and choose their own path with their doctor. Let's see, if we've had exome gene testing for illness, would any of these variants have been tested?
Oh, okay. You mean for erythromelalgia? So it's apples and oranges. I'm going to assume that if your neurologist is ordering gene testing to help with the diagnosis, that's not going to include pharmacogenetic testing. Maybe someday it will, but right now they're very separate. I hope that answers that.
Yeah, so just to clarify, there's the gene testing and then there's how you metabolize testing, and they're two separate tests.
Yes, two separate panels of gene testing, at least at this point in time.
There's just a question whether people have tried mextilotine and the
Oh.
Journavx which is very new. So I don't know anyone who has had the opportunity to try the new medication. And I believe some people do get benefit from mexiletine. Again, you have to work with your own doctor to determine if that's a good option for you.
Totally agree. Yes. So it'd be helpful amongst your group to pose that question to folks over time, especially with suzetrigine. Has anyone tried it? It's anecdotal, but that's okay. That has its place. Um, and we'll certainly know more in 6 months to a year. And I'm sure it's being studied for neuropathic pain. I'm sure those studies are underway.
We have another question. Should I ask my genetic doctor to test for all of these variants, or do I wait to test for a specific med?
Ah, typically, uh, it might be different for the HLAs because we've been testing for a while when someone's put on Tegretol, but it probably makes sense to have a panel done. And I believe that is where we're heading. That there's almost like the one I showed, the genes and drugs where there's really strong associations and we know what to do about it. Mostly we're testing for all of them. It's hard to explain. It's easier to do that testing. You do it with probes and panels, and you would get more of a comprehensive report that may test for things, for drugs and genes that you'll never use. So that's kind of where the testing's going, that there are these sets. That's a better way to look at sets of genes and drugs for pharmacogenetic testing. And it runs, so this is real ballparky. You know how medical billing's all over the place. Runs about $300 that hopefully sometimes you would have to pay, but considering your situation, it's likely you get that justified, but I can't promise that.
Right. Someone asked that did the gene site testing, that they didn't feel the results were that good. And I mentioned that you recommended the 1 ohm from Mayo Clinic as an alternative.
And it'll be similar. There again, we're a little early in this, and it probably wouldn't benefit you until you're a little bit further along in therapy where you're going to be starting to use lots of different drugs together. Does that make sense? Certainly, if anyone ever wants to prescribe carbamazepine for you, but your neurologist would know that. You would want that tested. I know I'm hemming and hawing a bit, but it depends on everything you're taking. Let's say you have heart failure and EM. That means you're going to be on a lot of medicines. I would want to know comprehensively what that might look like with all those different drugs competing for all those different enzymes and how that would look. But that's probably not most people.
Yeah,
Am I
that's
still hemming and hawing too much?
no. We have another question in the Q&A section, which is, when I was tested at the Mayo Clinic, they said that Wellbutrin could be causing the anhidrosis, which caused my erythromelalgia. Should I be
Oh,
pharmacology tested for this drug? It's a good question.
oh, bupropion, Wellbutrin. I'm not sure if that's not a big player, if you will, with pharmacogenomic relationships. Does that make sense? I don't think there's CPIC guidelines on the use of that drug. Uh,
Right. It's true that not every drug is in the test. I know because I've done the
yeah,
test before, and I was surprised, like a
yeah,
lot of medications were listed and many were not. So, and I think that's evolving
yes,
too as time goes on, more and more medications will be included. Um, and in this case, I'm not sure that anhidrosis would actually cause erythromelalgia. I think
yeah.
they're co-illnesses, if you will, and it's common to have them both together rather than one causing the other.
Yeah, I would agree. I'm not sure what they were trying to tell you. It sounds like you were just having a side effect from bupropion that had nothing to do with, well, there are other ways to metabolize the drug too, but didn't involve the you being more genetically prone to not getting rid of it. That's interesting. I might have to look, maybe I should look that up for you. Drop me a quick email and let me look that up and see what I can find. Okay.
Great. Well, thank you so much,
Thanks,
Kathy.
Elijah.
I can tell that this has been extremely well received, full of really great information. And thanks for your time
Oh, sure.
to answer these questions. And thank you to all the attendees and for your interest. This was recorded. And within the next couple of months, it will be on our YouTube channel. Keep in mind that we are an all-volunteer organization here at the Erythromelalgia Association, and a final plug for us in this is that in order for us to survive, we rely on solely on individual donations, which when you visit our website at burningfeet.org, you can easily donate whatever you can, and that would be much appreciated. And thanks to Meg for her help today.
My pleasure. Thank you guys, and thank you, Kathy.
Thank you, everyone. Have a
Thanks
good day.
again, Kathy. It was wonderful. Bye-bye.
Bye-bye.